All right, let's get started. It's 2 o'clock and we have some opening things so that if anybody's still joining us, they won't miss anything absolutely critical. Welcome to Bump Ahead, ensuring maternal and fetal safety on the road. Next, Cindy. I'm Suzanne Orgaitis-Jones and I coordinate the Child Passenger Safety and Occupant Protection Healthcare Project here at the Maryland Institute for Emergency Medical Services Systems. And Cindy Wright-Johnson is here with me, and she's the background person who will be monitoring questions. She directs my project and the EMS for Children program, and also will be a speaker today. Next. None of our speakers have any financial relationships to disclose with ineligible companies. All right, I'm not going to read this to you, and hopefully you all saw this in the promotional information for the webinar. But we have a lot we want to cover today, and I think it should all be pretty interesting and hopefully relevant for you. Next. Okay, our speakers. Let me read very short bios about each of our speakers, and I'm going to do all of them right now so then we can keep the content of the webinar together. Greg Colton is the Community Outreach Captain at the University of Colorado Health EMS, where he coordinates services including free seatbelt checks, car seat installation, and infant CPR classes to expectant parents. Greg has also served in various other EMS capacities in Colorado, including at Poudre Valley Hospital and Breckenridge Ski Resort. Abby Butler has dedicated her nursing career to improving perinatal and neonatal health outcomes at both the hospital and state levels. Here at MIMS, Abby is the director of the Office of Perinatal Programs. Abby holds a master's degree in nursing leadership and management and is currently pursuing a doctor of nursing practice degree. Elizabeth Wooster has 42 years of frontline medical care experience that includes work as a paramedic, emergency medicine nurse, flight and critical transport nurse, and trauma program director of operations. Here at MIMS, Elizabeth is the Director of Trauma and Injury Specialty Care Programs. And Elizabeth holds too many degrees and certifications to mention them here, but they do include a doctorate of emergency medicine, a master's of science in nursing, and even a degree in engineering. Cindy Wright-Johnson started as a pediatric primary care nurse at the Children's National Medical Center in Washington, D.C. Then in several different positions, she added to her clinical background with program development, education, and research for injured children and their families. In 1993, Cindy came to MIMS to serve as the program director for EMS for children. And then in addition to all the many committees she serves on in Maryland, she's the co-chair for the National Safe Transport of Children Committee, which is dedicated to looking at issues on children riding in ambulances. Cindy holds bachelor's and master's degrees in nursing. So go ahead and next slide, and I'm going to turn this over to Greg Colton. Go ahead, Greg, whenever you're ready.
All right. So my name is Greg Colton, as you heard from the intro, and I also apparently never sent the updated picture they wanted. So there's just like a picture of me from one of the pictures in the presentation. So next slide. So a little bit about the language and terminology that I'll be using. I'm going to say pregnant driver to refer to all seating positions and all statuses as a driver, or it's just easier to say driver instead of occupant for about 66 times. But also the reason that we say driver instead of occupant is to remind ourselves to expand our focus. So when we talk about child occupant protection, it's simply child passenger safety, and the main discussion is around crash survival. In pregnant occupant protection, we have the element of crash survival, but also crash prevention. So that includes controlling the vehicle, distractions while driving, all those kinds of things. I'm also shortened to prenatal vehicle safety to PVS, just because it's less of a mouthful. But I've also worked at Poudre Valley Hospital, or PVH, for the past 11 years. So if I say PVH, just know that I meant to say PVS. Next slide. So why is prenatal vehicle safety so important? So this is the average number of crash fatalities in the United States from 2017 through 2021, as divided out by age. The gray columns are ages 0 through 25 and up, divided by year. So you can see fatalities start off low and then stay low through childhood and then climb in the teenage years, peaking at 21, and then they taper off into adulthood. The very tall red column on the left is the average number of fetal losses due to crashes each year. And that average number is 1,405 fetal losses. That's almost twice as high as any of the other higher ages in the 20s. That's also 20 times higher than the number of fatalities for 0 to 1 year old infants in crashes each year. So that means that the baby on the left is at 20 times more likely to become a traffic fatality than the baby on the right. Or if you want to phrase it a little bit less gloomy, you can say the baby on the right is 20 times safer than the baby on the left. So this is why talking about prenatal vehicle safety is so important. Next slide. So it was a quick video talking about the 3 stages of a crash. We'll watch that real quick and then we'll continue on. I'm not sure if you guys have sound on your end. I don't have it on this end, but.
This all happens in about 1/10 of a second.
It's talking about how crashes
Following
happen
the
in
vehicle
1/10 of a
crash is
second.
the human crash.
The first crash is the vehicle hitting something. The second is
Hopefully,
the person hitting
and
something
airbags.
in the car.
If the occupants are not wearing safety
Or
belts,
hitting each
they will
other.
continue
Or
traveling
hitting the
at the
steering
same
wheel or
speed
the
as the
airbag.
vehicle was traveling, slamming into the dashboard, windshield, or some other part of the vehicle's interior. They may even collide with other passengers. When the occupant's body has come to an apparent stop, the internal organs
This is
are
the third
still
collision where
hitting other
after
organs or
the vehicle
bones
has
in the
come to
body.
a stop,
This
your body
internal
is
crash,
still moving and your
though
internal
silent and not
organs
visible
are
to the
moving
naked
and they
eye,
can hit
can cause
each other,
fatal
or your
injuries.
brain can hit the inside of your skull.
Statistically,
Your
it's
aorta
highly
can be
likely
moving so
that
much
you
it
will be
ruptures.
involved in several collisions during your lifetime.
So it's really 3
If you're lucky,
collisions in a
The
crash.
only damage sustained will be to your vehicle. Remember, a preventable collision is a collision in which the driver fails to do everything reasonable to avoid it.
On average, most people are in 2 to 3 collisions in their lifetime as drivers. All right, Greg, back to you. Sorry, I had to take over to narrate.
No, it's all good. Negative fetal outcomes aren't limited to just fatalities. Fatalities is the easiest thing to compare across different ages, but it's not just limited to that. Other negative fetal outcomes related to crashes include fetal distress, premature rupture of membranes, premature birth, low birth weight, C-section, and studies have even linked an increased incidence of cerebral palsy in children that were involved in crashes while in utero. Next slide. So with PVS, it's very important to talk about what injuries we are trying to prevent. And they may not be what people think. In fact, it's really not what I thought when I started looking into all of this. Direct fetal injury is what usually comes to mind first. And so direct fetal injury is basically something hits the belly, baby's inside the belly, baby gets hurt. Striking the steering wheel, pressure from the lap belt, pressure from the airbag, those kinds of things. However, while that's the first thing that comes to mind, that's only the cause for about 10% of fetal losses. Uterine rupture is another cause for fetal loss. It's basically just where the uterus splits open, and that's catastrophic when that happens. And you'll see it as a popular topic in case studies. You might think it's pretty common because there's a number of studies about it, but the reason it's in all these case studies is because it's so uncommon and unusual. It actually only accounts for about 1% of fetal losses. Getting into the main causes of fetal loss from crashes, we have maternal shock. So the pregnant patient loses enough blood that the oxygen flow to the fetus is compromised. and that accounts for about 20% of fetal losses. The reason this is such a big risk for pregnant patients is because they're more susceptible to the kind of liver and spleen and organ injuries that can cause massive internal bleeding. Their liver and spleen are pushed closer to the thoracic wall by the uterus as it expands, and so there's less space for them to compress into when the upper body moves forward in a crash. And so they're more exposed and less space to compress into there. And then on top of that, a pregnant patient can lose up to 1.5 liters of blood before the signs of shock are obvious. So we can be sitting in an ambulance on the roadside with a pregnant patient and they look fine, but they actually may have lost 1 liter of blood already and we don't know that that's been happening. And when a pregnant patient goes into shock, the body's already naturally diverted blood flow away from the uterus. So the baby's been in shock for a while if the pregnant patient's in shock. And the main cause of fetal losses and crashes is placental abruption. So that's where the placenta unsticks from the wall of the uterus, and that compromises blood and oxygen flow to the fetus. The reason this accounts for more than half of all fetal losses is it can occur with or without external force on the abdomen. So even if their belly didn't strike the steering wheel or something like that, you could still have that happen. It can happen with only minor injuries to the pregnant patient. So you might just see abrasions in the seatbelt and their neck's a little stiff and that's it. But they could still have a placental abruption even with just those minor injuries. It can result from low speed crashes. So they don't even have to be in a Fast and the Furious Michael Bay style car crash for this to happen. And the symptoms may not be immediately apparent. So it may take hours for symptoms to crop up, and that can delay treatment pretty considerably when those symptoms don't show up for that long. Next slide. So to see why placental abruption can happen in all these situations, we need to look at the forces acting on the uterus during a car crash. As you can see, there are many different forces acting on the uterus. Some are external, many of them are internal forces. So as we were talking about that video, there are 3 phases of a crash. So the vehicle stops first, and the body stops inside the vehicle, and then the organs stop inside the body. People, when they think about PVS, they often think about the body stopping. So what happens when they contact the lap belt or the airbag or the wheel, something like that. But actually only 2 of those arrows are a result of that second stage of the collision. So the force coming in from the lap belt and then the deformation of the uterus on the opposite side from that force. Those are the only things that happen during that second portion. Most of these other forces actually occur during the third part, where the organs are coming to a stop inside the body. And part of the reason that prenatal vehicle safety is such a big issue is because that third stage of the collision, limiting how much organs move inside the body, is the most difficult part of the collision for us to manage. So that's part of the reason that there are so many injuries to unborn babies in crashes. And then the crash test done with an accelerometer on an artificial fetus actually recorded the sharpest spike in acceleration when the dummy rebounded back and hit the vehicle seat back. So we think about the body contacting the inside of the car as it goes forward, but actually when it comes back after the car is settled, that's where we can see a big spike of acceleration there too. As you can see from all these different arrows coming from all these different directions, abruption can also happen no matter where the placenta is on the uterus. So posterior, anterior, superior, inferior, it doesn't matter where it's at. There are forces that'll be acting on the placenta, and a series of crash tests actually did show that there was an equally likely chance of abruption no matter where it was located in the uterus. So if you have a patient that you're like, oh, well, their placenta is posterior, it doesn't make, that's fine. The lap belt's on the other side of the uterus from them, like they should be good. Nope, they can still have a placental abruption too. Mechanism of injury is a very complex system, and it takes a very complex system to manage it. So just simply just telling people to place the lap belt low enough, that's not enough to manage all of those forces. Next slide. I think we're transitioning over to the next speaker for a minute.
Yes. All right, Elizabeth and Abby.
Great, go ahead. Great, thank you so much. So like Suzanne said at the beginning, we have no financial interest to disclose. And we're going to talk to you a little bit about the mechanisms of the trauma and both the impact on mom and the baby. So we know that motor vehicle collisions are a leading cause of trauma in pregnancy, and they both affect mom and baby. The recurring theme you'll hear us talk about is we've got 2 patients on board, and to think about both of those. And then we require multidisciplinary prevention and response, especially when we get to the hospital setting. We know that we're delivering the patient to the ED, obviously, but we also want to make sure that we're including OB and neonatal providers as well in that activation of response.
So we see about 170,000 pregnant women in motor vehicle crashes annually in the United States, and MVCs account for about 50% of traumatic fetal deaths. About 1 in 12 trauma-related maternal deaths are also MVC related. So it is a significant issue in the United States, and it correlates well with trauma being the #1 cause of death in the United States from 1 to 44 ages, 1 to 45 these days. Let's go ahead. So when you look overall at mechanism of injury and you look at blunt trauma, Greg talked a little bit about seatbelts, steering wheels, airbags, and anything else inside your vehicle you can be hit with or your body strikes. Rapid deceleration and shearing forces produce a huge amount of injury. The longer that deceleration is, the less injury you will see. When it becomes short is when you see a tremendous amount of force and kinetic energy that occurs. And kinetic energy is half the mass times the velocity squared. So if you increase the mass, you double the energy. If you increase the velocity, you quadruple the energy. When you're looking at shearing forces, that truly affects vessels and ligaments. And we'll talk in a little bit about why that matters in that. You want to talk about direct abdominal?
Yeah, so and then our third mechanism of injury we're going to talk about is the direct abdominal trauma. We know we can have an increased risk for uterine rupture and placental rupture with both of those, which Greg talked about a little bit about earlier.
Go ahead.
Then we have immediate physical risks. We've got abruption, uterine rupture, but then we've also got fetal trauma. So we're thinking about direct impact of the baby on the skeletal system, either the skull or limb fractures. Secondary to that would be hypoxia. We're thinking about the placental abruption and then how that placenta is pulling away from the uterus, and really that's the mode of transportation for oxygen and blood, and so secondary hypoxia to the baby after that. And then after that, we worry about preterm labor. So we know a large percentage, I think it's around 40 or 50% of these patients in motor vehicle collisions end up having some form of preterm labor, whether it just be contractions that are controlled after a certain period of time, but a big risk for preterm labor, and then ultimately fetal demise.
Correct. So the role of EMS is really important. Prioritizing maternal stabilization has to be the #1 priority, because what's good for mom is good for baby. You have to treat the mom first, and you have to assume these patients have a huge shock factor, and that shock is always hemorrhagic shock until proven different. Rapid transport to an obstetric capable trauma center is also really important, and realizing that across our country, those are long treks sometimes. And if you have someone unstable, please take them to the nearest facility that you have available. Short scene times are also something that is critical. These are patients you don't linger on the scene with. Efficiency, scene efficiency is very critical, and it makes a big difference in their outcomes. I want to talk about it.
Yeah, and then early alert to the hospital is essential. So we're really starting to look at, as a state, how we're notifying hospitals for pregnant and postpartum patients for all sorts of things, whether it be hypertension, stroke, and this is no different. We want to be making sure that we're notifying the hospital in a timely fashion for the multidisciplinary team activation. We want to get everybody, all hands on deck, all appropriate team members in the emergency department to care for these patients quickly. And then just to back up to rapid transport to obstetrical capable trauma center, we actually have 15 hospitals in the state that are a level 3 or 4 obstetrical center with a perinatal and neonatal center, and all of those are also trauma centers. So I would encourage you to visit the MIMS website to locate the closest OB center near you as a referral center to really best care for these patients.
Or if you're listening from another state, check out what's in your state so that you're already.
Yes, thank you so much. And that's why we didn't include a map, right? Because we know we have people from different areas.
Yeah. So it's really important that you begin with on the mom. It's important to know what a pulse ox is, what their heart rate is, respiratory rate. All of those things matter. And even calculating a shock index on those folks makes a difference. We know by research that any shock index in a pregnant female that's greater than 1 requires almost always some type of blood replacement given. So that is significant. Abdominal assessment is also significant and difficult, but figuring out where the pain is and the tenderness. And believe me, you're not going to be able to easily figure out if that's a spleen, a liver, or something from an OB perspective. But the goal and the management remains the same. Take care of the mom, support her vital signs, and again, short scene times. You want to do CPAPs?
Yeah, right. And so with CPL status, obviously, a lot of times for an EMS perspective, we can visually tell in a bad enough car accident whether or not the seatbelt was worn, whether we've got bruising across, and whether it was worn correctly. So as you can see here, we have a little graphic over there. Are we wearing the seatbelt correctly? And the answer is no, we're not. We're not down there. Black belt is too high up above, really more like the umbilicus there. So those of you paying attention, yes, that is not a good picture. And then following that, and then finally just communication in the ED, like we're reiterating, it's just communicating to make sure we have OB and neonatal, the teams ready in the ED if necessary.
So once the victims come into the emergency department or into a trauma resuscitation bay, they really should be met again with OB and neonatal teams. This is a full team trauma team activation if there's unstable vital signs or if significant injury is suspected. It is critical with those other folks to have them on board for things like the fetal assessment monitoring by the OB team, and Abby's going to talk about that a little.
Right, so I encourage you to, if you are in the inpatient world or the outpatient world, wherever you work, wherever you deal with patients, to go to the EDs, say, hey, can you show me the warmer? What would an emergency delivery kit look like in this situation? And just really assess your readiness for this. And then for fetal assessment and monitoring, the OB team, for those OB folks on the phone, we are gung-ho. We are excited to go down and monitor patients. So ED providers, do not be worried about that. We're happy to go down and monitor as long as we need to. And our providers, our OB providers, are happy to come to the bedside and do an abdominal ultrasound to just check the status of things, and then we will do continuous fetal monitoring at the bedside as well for as long as necessary, or at least until things have settled down and we are cleared to go up to the OB unit.
So when you're looking at maternal assessment, this is something that we started to talk a little bit, a couple slides of so far, but looking at circulation, ABCDs, and do we need to prioritize circulation up front? And I would argue that all these patients get prioritized of circulation up front until we know any different. It is really important to do that left lateral tilt and get those patients off of off of the vena cava. The vena cava gets compressed with baby, and that does not allow the venous return back up to the heart, and it decreases the cardiac output. When you think about some of the physiology changes that happen with someone who is pregnant, blood volume is increased, okay, quite a bit, 30 to 50%. Some books as high as 50% they've recorded. That increases the cardiac output. The heart's already working harder. Just with normal physiologic changes, they have a higher heart rate. Remember, cardiac output, stroke volume times heart rate. Their blood pressure is a little bit lower. And you wonder, how do you have a higher cardiac output and a lower blood pressure? Well, I can tell you they're vascularly dilated. So they get vasodilatation because of the hormonal changes. They already have an increased oxygen demand because of the baby, of having to supply that. And when you have a traumatic injury, immediately your oxygen demand across your body goes up quite a bit. Aggressive resuscitation is required. You should not delay or withhold anything that you would do for someone who is not pregnant. So symptoms, again, Abby talked about symptoms may be seen in a baby first. They may see them with monitoring before you even see symptoms, a notable hypotension in mom.
Absolutely, yeah. And those of you that have taken care of a patient that receive an epidural that works a little too well, we know that we actually see it in the heart rate monitor in baby well before mom starts to feel woozy and needs an alcohol swab to stay upright. So we definitely see the impact of hypotension in baby before we see it in mom. So that's definitely something to keep an eye on. And then as well, just a note of that left lateral tilt. So we talk to EMS professionals as a quick way to know a rough estimate of how pregnant or what gestational age a pregnant person is, the umbilicus. So that's kind of the mile marker of 20 weeks. If we're at the umbilicus, we're about 20 weeks. So anything above that, we're going to benefit from tilting.
All right, I'm going to intercede because I don't know what that means as a non-clinician. What is the umbilicus? And I'm probably not the only one.
Yeah, so right at the belly button. So if you put your hand, if you just follow up the belly, and if you can really rest your hand at the top of the uterus or the hard, the hard part of the belly, and you're right at the belly button, we're about 20 weeks. Yes. So at the fundus. I know everyone, the fundus is very, as well known. But yeah, so if you're at the very top of the uterus, the hard part where the baby is, you're at about 20 weeks gestation. So yeah.
So I wanted to spend just a couple minutes on some maternal and fetal diagnostics that need to be done. A FAST exam, which is a focused abdominal sonography for trauma, can be done on these patients right up front. And there's a lot of advantages to doing that. For one, they can see blood in the abdomen. They can also look at the heart and look at that quickly. Immediate ability to be able to identify the fetal heart rate and movement, and then eventually to an ultrasound. You should not withhold CTs or x-rays. If these folks need CAT scans, and that's routinely what needs to happen with somebody like that, then they should be getting those. Lab work is important. At a trauma center, you would expect them to have trauma labs identified that they send on these folks up front. Please make sure that you include a fetal dex or a Kleihauer-Betke, which I probably didn't say that correct, but fetal dex is how it's been known across this country for a long time. And what that does is look for fetal cells in the maternal blood that you draw. There's a couple additional things that are really important. If you only have a little bit of blood, a type and cross in this situation is critical. Okay, because you can give uncross-matched blood to this mom, or if you don't have O negative blood where you are and you have to give O positive blood, you need to get a type and cross right away in case they have a funky antibody. Blood gases are important. That helps us identify where we are in shock. What is our base deficit? How wide is it? What's our pH? And then of course lactic acids and coax, PT, FD. PT, PTT, INR are really important. they can have any injury we can have, anybody else not pregnant can have. Okay, but some of the big things there are pelvic fractures. Some abdominal injuries can be masked because it is more difficult to figure out a spleen in the liver. Okay, it's really difficult to figure out a hollow organ injury like a bowel or a pancreatic injury, difficult in this population. Pelvic fractures certainly are also there. And remember, during pregnancy, ligaments that attach to bones are lax because of the hormonal changes that are happening. And so what that does is make a joint space become more vulnerable to injury because it's not held as tightly into that space as normal.
Yeah, and for risk of preterm labor, we actually, you can actually see that the fetal dex or the Klein-Howard-Beck test actually can be an indicator of risk of preterm labor. And so a lot of times, even if mom isn't necessarily Rh negative and we're worried about the blood crossing from mom to baby and vice versa, we will see that test run as an indicator for risk of preterm labor.
And please don't miss shock. Shock is so important, and sometimes shock cannot be easy to figure out. That's why you really need to focus in on your good clinical evaluation of that patient and send the appropriate labs up front. Blood gases are real-time medicine. And so being able to understand what that pH is and what that base deficit is, which is the amount of oxygen demand across the body that's not being met. So that's pretty critical to understand. And again, that fetal dex up front. Go ahead.
So we talked a little bit already about signs of fetal compromise, but we've got change in fetal movement would be a big indicator. We know that when we triage our OB patients, huge red flag, huge immediate, like get to the emergency department, come see us, is a change in fetal movement, and that'll be the same for these patients as well. And then as well as a change in fetal heart tones. We know the patient will be hooked up to the monitor. We'll be monitoring them for 4, 6, 12 hours, depending on your OB provider. Vaginal bleeding, leakage of fluid, also huge red flag. If we've got a patient that calls in with any of that, it's an immediate evaluation at the bedside. And then we've got uterine tenderness and contractions. And we mentioned before that about half of these patients in a motor vehicle collision are going to end up with some form of contractions, some form of potential labor. So,
hey Abby, I have a question.
Yeah.
How do you tell the difference between urine and leaking amniotic fluid?
Great question.
Because people leak urine.
Right. And there's really no way for a layperson or somebody at home to know, or on a scene like this. We have to get you in the facility. We have to either do what's a Ferning test where we're looking at our microscope, or a litmus test that we can test with a little bit of paper. So we really just have to have you at the bedside. We have to lay our eyes on you. We have to, believe it or not, smell the fluid. and some of you will say, oh, that's gross. But there's a distinct smell for amniotic fluid versus urine. And really those are the only ways to know. But great.
Thank you.
Yes.
So there's a lot of risk factors that can increase your risk for poorer outcomes. And they're listed here, but high speed, again, increases that kinetic energy, and kinetic energy is what causes that injury overall. It's the energy that causes the injury. Seatbelt use, I know Greg is going to talk about the proper use of seatbelts, but they definitely should be used. You want to talk about late gestational?
Right, late gestational age, like we said, we talked about, where the baby comes up in the pelvis, and obviously a bigger baby is going to have more surface area and a larger risk of trauma and injury to the fetus. That's pretty much it for that. But
the increased time that the mother spends in a shock state decreases the risk or the survival probability of both the mother and the baby. That's really critical to understand. You have to be aggressive with these folks with resuscitation. This is not a patient where you stair step a few things, then you see what that shows, and then you stair step a few other things to order and you see what that shows. These are people that need to have a good algorithm up front, that you need to follow that. You need to follow ATLS guidelines for resuscitation with this mom. And what's good, again, for mom is good for the baby. You want to talk about multi-system?
I was going to talk about
Delay.
Yeah.
Go ahead.
Okay, and then just delayed recognition or placental abruption. We've got, Greg mentioned a little bit before, sometimes you can tell, but a lot of times you can't. And so delayed recognition, delayed care for these patients, as well as a lack of fetal monitoring in a timely manner are all going to increase our poor outcomes. We really want to get the fetal monitoring on the belly. We really want to get an ultrasound on that belly to see what is going on in there and to confirm that the baby is still okay. All right, and just to take messages from us is that timely trauma-informed response improves outcomes. We want the appropriate people at the table or in the emergency department. We want OB there. We want the neonatal team there. And when possible, we want to go to that OB-capable trauma center. That's where these patients belong. Aggressive shock management is the key to survival for both mom and baby. And what's good for mom is good for baby.
Okay. Well, thank you, Elizabeth and Abby. That was, well, certainly for me, it was not as a prevention person, as not a clinician, I learned a lot. But we're going to hear a little bit more sort of on the clinical end from Cindy, and trying to jump ahead of some of your questions. She's going to address what happens. Go ahead, you can click. Go one more. There you go. What about out of hospital deliveries and the transport of newborns in ambulances?
I want to share with you what we know and what we don't know. Suzanne asked me to cover this very briefly. There's a whole nother hour or 90-minute lecture that we do on this, and we've been working on this since 2009. The real decision when we have two patients, whether this has happened because mom has been partway to the hospital and gone into labor, mom has gone into labor and tried to get to the hospital, or there has been a vehicle crash, as we've talked about, or mom is at home and you're responding to the home, you now have two patients. And the real question is, are we going to do two transports? Is that what is safest? Or are we going to co-transport, which is a term we've really only used in the last 5 to 10 years? And the honest answer is it depends. It depends on the clinical stability. If both mother and the newly born infant, less than an hour old, are stable, you've been able to do repeated vital signs every 5 minutes, their vital signs are normal, you do have them both on a monitor, and you're able to keep them warm and dry, get them dry and keep them warm, then you really do have a decision. If you look on the left slide, there are devices that have been tested to the manufacturer's belief of what is stable and safe, because that's all we have right now. The one that is featured there is called the Kanga Fit. The child goes into the device, and then the neoprene is put inside a restraint, and then they are placed on mom or on dad. If only the baby is stable, that could be dad, or could be another mom or another member of the family. You also have the option of transporting mom by herself on a stretcher and the infant on another device. And I'll show you a couple of those in a second. You could have a captain's chair, is what we commonly call them, that has an integrated infant seat, but it would need to be weighted down to the level of the child. And most of these devices go down to about either 3 or 4 pounds. If either mom or the baby are unstable, then you are looking at 2 vehicles and 2 different transports, because mom needs to be safely secured and monitored, as does the infant. What you have on the right side of the device is the very, very old, what we've done for decades, which is to put the infant in the car seat they were meant to be in and try to secure them. But you'll notice this is not an infant seat. It is a convertible seat because there are 2 belt paths. This has been tested but it is not in favor by the car seat manufacturers, but it is clearly better than what I'm about to show you on the next slide. Above it is something called a neomate, which is meant for infants that are anywhere from 4 pounds I'm sorry, 5 pounds up to 14 pounds. So it can be used on an older child, and the child is secured with a monitor and having been kept warm directly onto the stretcher. These are other 2 devices. This is the baby pod, which allows for some ability to keep the child warm and secure. This then gets attached to the stretcher, and then obviously from hospital to hospital, we'd be using a neonatal transport. What we also know, sorry, I went too fast, is that there's one thing we cannot do, and unfortunately it is our most common answer on quizzes when we do displays. Mom, dad, another responsible adult, even another EMS clinician may not use their own 2 hands to hold a child, because in a sudden stop or in a vehicle crash, the child would then be ejected somewhere else into the ambulance. I do want to make a real clear disclosure that even when mom and baby, and this was a home delivery, are on their own stretchers going into their own ambulances, neither of these moms is correctly restrained. We do need to remember that mom needs to be safe once everybody gets to definitive care, and that we need to have mom correctly restrained. There's a lot more to talk about on this, not today, but the standards have been drafted, the standards have been vetted, and we are now waiting for a foundation or federal funding to sled test the standards, just as all of our stretchers and our vehicles and our car seats currently are tested.
Thank you, Cindy. I know that was a big ask to try to cover all that in just a couple minutes and 2 slides. We're going to turn it back over to Greg now to talk more about seatbelt fit for pregnant women.
All right, so we were talking about all of the risks of being in a crash while pregnant, the treatment for it, all the kinds of things. But we can also look at how we can prevent all these injuries and how we can save ourselves, all of that clinical work we've been talking about. So proper seatbelt use reduces the risk of adverse fetal outcomes by 84%. So simply wearing seatbelt correctly reduces the risk of all those different things we've been talking about. Every passenger vehicle has seatbelts. We just simply have to use them correctly. Next slide. So we have a ton of evidence that shows that seatbelts help pregnant drivers in crashes. I had to use size 8 font to get it all on the slide. And don't worry about trying to read all of it. This was just as a visual aid to show how much evidence there is. You can just go to the website. I'm going to talk about it a little bit if you want to read all this. Next page or next slide. Yep. We also have evidence that strong evidence that airbags help a pregnant driver in a crash. There aren't as many crash test-based studies on this, so the slide does not look as impressive. But there is still tons of evidence that airbags help. Now, despite us knowing about all this evidence as clinicians and as car seat techs, we know that these are helping, but about up to 40% of pregnant drivers are still hesitant about their seatbelt and their airbags, and they're hesitant about if they are going to be helping them in a crash or think they may even hurt them in a crash. So please, when you're working with pregnant patients and pregnant drivers, tell them about how much evidence we have and that seatbelts and airbags will help them. Next slide. Now, to be fair, that 40% of pregnant drivers who are worried about their seatbelt aren't completely wrong. Seatbelts are awesome and save lives, but they do also pose risks if they're used improperly. The risk of placental abruption increases 50 times if the driver has their lap belt too high on their belly, like the model in the stock photo does. And this is not to say that seatbelts are dangerous as a whole, or we should change the seatbelt or modify it. This just underscores the importance of wearing the seatbelt properly. So if wearing seatbelt properly is so important, the next question would be how many pregnant drivers wear their seatbelt properly? Next slide. Only 15%. So 15% of the pregnant drivers who had a seatbelt check done down at their car wore their seatbelt and adjusted their seat correctly. That means that fewer than 1 in 5 pregnant drivers are getting the full benefit of their vehicle's safety devices. So it's a very, very low rate. It's worse than the missed rate used for car seats, and definitely we need to see what we can do to help increase this rate. And we have found that we can change this with education. Next slide. So for PVS education, we use a 3-tiered approach for educating pregnant drivers. The first is with informational materials, so flyers, posters, websites, social media, those kinds of things. The second tier that provides more education is in-person seatbelt education. So actually sitting down with a pregnant driver for a few minutes to talk to them about their seatbelt. And then the highest tier and most effective education for pregnant drivers is a prenatal seatbelt check. That's where someone goes out to the pregnant driver's vehicle with them and systematically goes over their seatbelt, similar to how we do car seat checks for kids. Next slide. So this is the correct use of seatbelts divided out by level of PVS education. The green columns represent correct use and the red columns represent incorrect use. Starting on the left, we have no seatbelt education. So the driver was not spoken to by someone, they didn't receive a flyer, see a poster, nothing. Only 6% of those drivers who did not receive any education wear their seatbelt and adjust their seat correctly. Now moving to the right, we have informational materials only. So they saw a flyer, they got a poster, wait, other way around, they saw a poster, got a flyer, but were not spoken to in person about their seatbelt. Informational materials definitely help. They more than double the rate of correct use. If nothing else, we need to get info materials in front of pregnant drivers. Now, the rate of correct use is still only 14% though, so if we're able to get more education to them, we definitely want to do that. So next, in the middle there, we have in-person education. So this is any amount of education. Just someone talked to them about their seatbelt. It could have even just been someone saying, hey, put your lap belt under your belly. They got at least some in-person education. And we can see there's a huge jump in proper use. So we really need to be talking to pregnant drivers about their seatbelts. And then to the right again, we have education with a visual aid. So these were drivers that we could confirm that they were educated by someone trained at educated pregnant drivers and using a visual aid to show them about their seatbelt and their seat adjustment. This gets us all the way up to 70% correct use. So clearly, like, not just getting in-person education, but high quality in-person education is necessary. And this is education that can be done by anyone. It does not have to be a car seat tech or someone trained with a vehicle safety background. And finally, we have the highest level of education. So that's a prenatal seatbelt check out of the driver's car with a technician, just like a car seat check. This is the best way to ensure a pregnant driver is maximizing their safety devices. And this data, all of this education data I forgot to mention, came from the 2,800 or so prenatal seatbelt checks that have been done so far. And the last column, that info came from drivers who got a seatbelt check and then were kind enough to come back and get a second check to see how they were wearing their belt and adjusting their seat. Next slide. So for info materials, the first thing is just flyers and posters. So there's a lot of great flyers out there. NHTSA, the National Highway Traffic Safety Administration, has a great flyer that you can download. It lays things out in an easy to understand way. It's available in English and Spanish. I also put together a flyer that has for everything for a pregnant driver on the left and then a buckled up pregnant driver on the right. It's currently available in 16 languages and it can be customized with your logo because like our health system, you can't use something that says someone else's health system on it. So if you wanted me to swap out the UC Health logo, I can definitely do that for you. And you can download that on the website that I'll be talking about in a minute. And I might be updating this flyer soon too, so stay tuned for that. Next slide. Then also on info materials, there's a website that I put together. It's got information for both pregnant drivers and for professionals. So for pregnant drivers, it has how to wear your seatbelt, the list of evidence that supports seatbelt and airbag use that I showed you earlier, what to do if you're on a plane and an RV, et cetera, and information on seatbelt adjusters, which we'll talk about those in just a minute too. And then for professionals, there are downloadable versions of all the resources, and there are also links to 88 research articles. So if you would like to research all of this stuff on your own, then you have a starting place there. One word of the caution, if you're reading all those studies, the case studies get kind of dark, so don't read them if you're scared of crashes and things. Next slide. And then the next stage of education we have is in-person education. This is the best way for non-car seat techs to increase the safety of pregnant drivers and their babies out on the road. It's very impactful and it is very easy. It only takes a couple of minutes and can be done by anyone who interacts with pregnant drivers. It can be done by car seat techs, providers, medical staff, nurses, childbirth educators, prenatal yoga instructors, anybody that's interacting with pregnant drivers can give this education. That's me talking to my buddy Callie at a safety fair about her seatbelt. And it can also be done individually, like me and Callie here in this picture, or it can be done in a group setting, you know, at a prenatal class, things like that. And as we saw from the data, it's very important to get that high quality in-person education. Next slide. So to help provide that high quality in-person education, I made a seatbelt use during pregnancy teaching tool. So on the front, it has what to do and what not to do. Then on the back, it has all of the talking points to the person providing the education. And then it also has information on the website, on how to get to the website. So this is designed so that you can hand this off to someone with no training and no background in prenatal vehicle safety, and they can just read the back and then educate a pregnant driver. So this can be used by anyone. Some of our clinics keep these in the little slot on the door for paperwork and stuff in the exam rooms, and so people can pull that out real quick and talk to pregnant patients. You can post them on the walls places. One of our OB clinics has these posted in the bathroom, so patients can see that when they're at each visit, all those kinds of things. So, and this is downloadable on the website too. I also have loads of them printed out, so if you want some, I can send you some. So, and then next slide. So to show you how quick and easy in-person education can be, I'm going to give you the actual spiel that I give to pregnant drivers. So first, you place the lap belt below the curve of your belly so it rests on your hips. For a lot of pregnant drivers, it helps to turn the lap belt over as it passes underneath your belly. Then you want to wear the shoulder belt to the side of your belly and across the center of your chest and collarbone. You want to sit in a comfortable upright position. If you lean back a bunch, that can make the lap belt wander up your belly, and the shoulder belt will hit your shoulders nicely there. Then you want to adjust your seat so you can press the brake pedal all the way to the floor with the ball of your foot on the pedal and grab the top of the steering wheel with your arm still slightly bent. Then you want to tilt the steering wheel so the airbag is directed toward your chest, not towards your belly or your face. Then you want to make sure there are at least 10 inches of space between the center of the steering wheel and your chest so the airbag has time to fully inflate before you contact it. Done. That's it. All that little spiel is what can push someone up to having that 70% chance of wearing their seatbelt correctly. Super easy to do, and hopefully we can get this out there for every pregnant driver that we're interacting with. Next slide. And there's some other education tools that we put together for helping with in-person education. And I always forget the financial disclosures things. I'm going to say that before I do this slide. I don't benefit from anyone going out and buying all these. These are just things that we helped design to help all of you out with education. So we worked with Huggable Images. If you're a car seat tech, you might be familiar with Huggable Images training dolls for car seats. So we worked with them on making an adult size pregnant training doll for showing seatbelt use. And then we worked with, and you can get these on their website. We also worked with Seatbelt Planet to create a seatbelt trainer that can be used on any chair without needing to use a special training chair, because anybody who has lugged one of those chairs around will know how heavy and hard to work with they are. And anyone who's ever tried to buy one can tell you how expensive they are. So this is a seatbelt that'll just attach to any chair. So if one of those would be helpful for you, just let me know and I can help get you set up with one of those. And then on the bottom there, that's the tool that I use the most, is simply just a loop of seatbelt for talking to pregnant drivers about how to wear their seatbelt, how to place the lap belt, and all those things. And this is the tool that I use the most often, and I can send you info on how to get one of those too, or if you have an extra ambulance cot strap or something, you can make your own, whatever you'd like to do. So I guess depending on how dirty that cot strap got before it was taken off the cot. But all right, next slide. And then the highest level of prenatal vehicle safety education is a prenatal seatbelt check. So going out to their car, sitting down with them, going over how to wear their seatbelt. These are specifically designed to be quick and easy, so you can just tack them right onto the end of a car seat check. You can do it right at the the end of an appointment, something like that. It only takes a couple of minutes. They don't require much extra training, so if you're already a car seat technician, there's just a quick little bit of training I can run you through, and then we can get you going with doing seatbelt checks, especially because like half the training is this presentation, so you're already half or more than halfway there just by coming to this webinar today. Next slide. There is a technician guide that I've put together and I'm currently updating, so there'll be a little bit of a delay if you'd like it, because I need to finish the updates on it. But there's a technician guide and a prenatal seatbelt check form for the prenatal seatbelt check process. So if you are interested, if you're a car seat tech and you're interested in offering this at your program, please let me know and I'd be more than happy to help get you started doing this. Next slide. And then I have a couple of minutes to talk. They would like me to talk about seatbelt adjusters. These are an important issue we run into in prenatal vehicle safety. So for people who aren't familiar with these, seatbelt adjusters are a device that modifies the seatbelt routing so that the lap belt is no longer resting on the belly. The intention of this is that it would make the pregnant driver and the baby safer in the car because the lap belt's not pressing against their belly. These are very aggressively marketed to pregnant drivers. And before I go further, if anyone listening to the webinar is a pregnant driver or has one of these, I want to thank you for thinking of your baby's safety and for doing the right thing. Unfortunately, though, these are not recommended. These are a non-approved device for all the car seat techs listening. But what that means is this is something that the seatbelt manufacturers, the vehicle manufacturers, they have not tested and approved using this with their equipment, and they don't endorse using it and won't back up how their equipment performs with this. So they're very, very dangerous. We also don't know what this will do in a crash. So manufacturers of these claim that they're crash tested, but they don't actually publish any crash test information. So we don't know if they really were tested, and if they were, like, how'd that test go? The other thing is that we don't have any data from crashes or crash tests. So we don't have case studies, sorry. So we don't have any population studies or case studies on these seatbelt adjusters because we just don't have enough pregnant drivers who've been in crashes with these for us to really know what's gonna happen. We know without a doubt that the seatbelt, when it's used as recommended, is going to increase a pregnant driver's safety. We don't know what this is going to do, and all we know is that the seatbelt is not going to function like it's designed to. The seatbelt is designed to direct crash force to a pregnant driver's pelvis and away from their belly. This device is now routing it out over their legs, and we don't know if it's going to put enough force down on their legs to restrain them, if it's going to put down enough force to injure their femur. We have no idea what's going to happen with this, it's just something we really want to avoid using if we just simply don't know what's going to happen at all with these. What I can say though, so disclaimer, we don't know for sure what this device is going to do in a crash, but since the one you see in the picture is a plastic hook that straps to the vehicle seat and you just place the lap belt through it, I am skeptical that it's going to remain in place and remain intact in a crash. I've broken similar ones of those in half just with my hands. You just flex it and it'll snap in half after not even applying that much force. And a pregnant crash test dummy ran in a series of tests that were done in Japan, contacted the lap belt with almost 2,000 pounds. So when we putting that kind of force on the lap belt, we don't want it to be going through something like a plastic hook. We don't know what these are going to do, so we super don't recommend these. They're dangerous. And honestly, the way I describe these to pregnant drivers and I'm talking to them about these is that it's a scam. It's just someone who's trying to get $40 out of you for a little plastic thing that cost them $5 to make. So, all right, that is all the slides that I had. Oh, and thank you for adding my email to the slide because I forgot to do that. So my info is there. Feel free to reach out to me anytime. You can shoot me an email. There's also a contact us on the website if you don't have that. And the website is Hudson Center for Prenatal Vehicle Safety, or hcpvs.org. So you can also reach me through there. So thank you very much.
By one. I know we're running out of time, so I put a lot of the handouts that were mentioned up that you can download them through GoToWebinar. But going onto the website, that, as Greg mentioned, would get you a lot more in all those, 16 different languages of these. That's phenomenal. That's a wonderful resource. Cindy, advance once more, and I want to explain CEUs again. Okay, now we could go back to some of the more technical questions. What are the differences in outcome depending on the stage of pregnancy? In other words, trimester. Elizabeth or Patty?
Patty's got to answer. Yeah, and Greg might have some information too from his perspective, but I think we know that from a UK study that there is a higher risk of bad outcomes in the second trimester as opposed to earlier on or later. But I can tell you as a state, we don't have a really good way of collecting that data. And you can imagine why. Our EMS providers in the field, they have a certain number of spaces where they're documenting, and a lot of times they don't know the gestational age, or the patient doesn't know the gestational age, or it's not communicated, or it gets lost in translation. So for that reason, we don't have an accurate way of collecting gestational age to really have a better answer for that question. And also then we've got a series of patients who don't end up necessarily being hospitalized after an accident or refuse care, and so we don't necessarily capture them in the hospital world. So we don't necessarily have a good way of knowing that. But we've seen other studies that say in the second trimester you have a higher risk of bad outcomes. Hope that answered the question.
Great, thank you. Any other technical questions there, Cindy?
There's a question about the presentation, and the presentation will be placed out onto the MIMS YouTube account in an archive, pardon me, media format, so you could replay it. The links to that will be on our website, which is mims.org. Go to EMSC and then CPS. And obviously, if you email CPS at MIMS, we'll be happy to send you a link.
And continuing ed credit will be available for future listeners for a year or 2 years, depending on which certification. But you will have to do the quiz. Everyone will have to do the quiz if they go and listen to it later. But it will be available, so feel free to share the information with others. As speaking for myself as a child passenger safety technician, I know I do often talk to parents, or expectant parents, I should say, about seatbelt use, but I'm definitely going to make that an absolute for my car seat checks. So thank you, Greg, for really bringing that point home. Looks like we have another question.
Yeah. How long should pregnant post-crash patients be monitored, fetal monitored, for minor crashes? Is this recommended for all weeks of pregnancy, first through third trimester? So I see two questions from Pam. One is, how long after the crash should the baby and the mom be monitored? And does that vary between the 3 trimesters?
Yeah, no big variance in the recommendations. Hi, Pam, it's Elizabeth. The recommendations still today are between 2 and 24 hours. And obviously that 24-hour time grows as it relates to symptomology that you're seeing on that fetal monitoring. It is critically important that these folks don't get discharged home without that fetal monitoring happening up front, especially if they're greater than 20 weeks. So that's the answer in a nutshell. There's a ton of literature out there, and if you look at most of it, it has the 2 to 24-hour time frame listed within it. Thanks for the question.
Yeah, and there are a lot of great algorithms out there that you can find as well, whether it be ACOG based or another entity. But there are really algorithms you can follow down. Does the patient have this? Then you recommend this, and it actually includes testing and fetal monitoring times as well.
Thank you. Any other questions, anyone? Last chance. Thank you all for attending. Thank you to my speakers. I think it was wonderful. Hopefully everybody learned a lot from it. Again, I certainly did. And have a good rest of the day and a safe day.